All set.
Excellent. So we have a couple of individuals joining us already. We'll get started just a couple minutes after the hour. Excellent. I see a lot of individuals joining us. We're super excited to get started here. We'll get started in just a moment. Thank you all for joining. Get started in about a minute. Okay, well, welcome to our happy hour webinar and question and answer. We're going to go ahead and get started with going over the agenda. So first and foremost, my name is Jenna Lindgren. I'll be your moderator for the day. I'm also the Director of Marketing for Atlas Lift Tech. We're a mobility solutions provider. Our mobility coaches across the country are fighting immobility at the bedside with care staff daily. They're inspired by our key opinion leaders who you'll hear from today. We're excited to celebrate Worldwide Pressure Injury Prevention Day alongside the National Pressure Injury Advisory Panel with a happy hour. Atlas supports mobility as medicine. Part of its mission is to provide free clinical educational content rooted in research. Thanks to our experts for being a part of this mission. And thanks to you for tuning in for this timely topic. We hope that this wisdom will help you at the bedside or the C-suite in your pursuit of a happyless journey. So with that, we'll start with talking about some housekeeping items. Make sure that you're well prepared to engage throughout the webinar. We want to get to know you a little bit by launching some polling questions and get the juices flowing. I'll introduce you to our speakers and experts in pressure injury prevention. And they'll review a hospital case study and answer some questions and then provide some closing remarks. So with that, let's make sure that you're ready to go on the Zoom platform. Important to note that this platform is unidirectional, meaning you don't have to worry about muting your line for the barking dog in the background. Also, there's a Q&A box at the bottom of your screen. We want you to fill that box with all of your questions because we will provide time for our experts to answer those questions and you can learn from one another. Important to note that if you do ask your question anonymously, we won't be able to connect you with the speaker if you'd like to talk. Also, the polling questions that we're going to launch here in just a moment, we won't be sharing your answers on the screen. We'll just show the results in aggregate. Lastly, we're going to send you an evaluation post-webinar. We know that taking an hour out of your time is a lot to ask, and we want to make sure that this continues to be a valuable resource for you and that we get better every time. So with that, let's get started with some questions. So for those of you who watched our video series, The Pursuit of Happyless, a 3-part journey, we want to know what you liked best. And don't worry, if you didn't get a chance to watch any of these videos, they're available for you on demand. Just go to mobilityismedicine.org. So let me launch this poll and I'll give you all just a few minutes to answer the questions. So did you like the content, the speakers, the video was short and to the point, the video length was extensive and the right amount of time, or all of the above? I'll give y'all just a few seconds to answer these questions. Awesome. Awesome. Still have some votes coming in.
I always want to play the Jeopardy song.
I know. Da, da, da.
Yes.
Okay, so let's see what the results are. So 31% of you liked the content, 15% of you liked the speakers. Some of you liked, 8% of you liked how extensive they were. They were the right amount of time, and 62% loved all of the above. Awesome. Okay.
We'll take that.
We are going
Yes.
to. That's right. That's right. All right. So the next question. We'd love to learn who's in the audience today. So do we have any RNs? Do we have any WOCNs? Do we have care techs, nursing administrators, physical therapy, industry, or other?
Dun, 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 dun.
I know. This is good.
I don't know how to plug in background music. I'm not that tech savvy.
I know. Okay, so let's see what the results are. All right, so we've got 26% of you are RNs, 37% of you are WOCNs. We don't have any care techs. We've got 15% nursing administrative, 4% physical therapy, 19% industry, and 22% other.
That's a nice variety. That'll be good.
It is, it is. Okay, so our next question. Is your unit or facility successful at achieving Q2 turns? So this is simply a yes or a no.
I'm going to be fascinated by the results of this one.
I know. Got 50% of the votes in. Numbers still creeping up.
All righty.
Give you guys a couple more seconds. What do you guys think? What do our speakers think it is?
Probably no.
I think it's also no.
Go with yes,
All right.
to mix it up with our panel.
Thanks, Bill. All right.
All right. So you took a risk and mixed it up, but 77% are no and 23% yes.
The split is consistent
Okay.
with the dynamics of the panel, so I'm happy with that.
Okay, next question. Does your facility have a specialty bed management program in place? So this is also simply a yes or a no. Yeah, a couple more seconds. Do our speakers want to guess at this one?
I would hope yes.
I would go with yes.
I'm going to say no this time.
Love it, Bill.
The three of us are consistent.
Okay, here we go. You are correct. 92% to 8%.
Nice.
Okay, next question.
Fiscally responsible to have one of those.
That's right. That's right.
Ooh, it's cost effective.
Okay. What is your unit's current rate of hospital-acquired pressure injury? So this is just your unit, and I'm going to provide you a range here. So is it less than 5%, 10 to 20%, 30 to 40%, or you don't know? This is also fun to kind of see benchmarking where everyone lies.
My guess would be if I'm in the ICU, it may be 10 to 20%. If I'm in a med surg environment, it may be less than 5%.
I agree. So we'll see how people split out. Yeah.
Yeah.
Okay, Dr. Padula, are you gonna go against the grain again?
I'm gonna go. I like that 10 to 20%. That's probably kind of ICU, nursing home, home health settings across the board.
See what we got.
Dr. Padula wins. Oh well,
No,
38 to 29.
And then
You take second. You take.
I think we all win when people say less than 5%.
That's correct.
I would 100%
That's a
agree.
great answer. I'm good. It's good to see that.
Yeah, totally. Okay, so we asked your unit. Now we want to know your facility. So what do you think your facility's current rate of pressure injuries are? And we're going to give you the same windows. So less than 5, 10 to 20, 30 to 40, or don't know.
I'm going to be optimistic and go with the less than 5 because you got a mixture of the ICU and med surge.
I agree, Kathleen.
The national average is right around 4 to 4.5%. So
Right.
should be less than 5 on average.
All right, well, let's see.
Yep.
Okay.
You all are correct. 55% to 36, 10 to 20. A few of you are unsure. Okay, last question. Are your pressure injury rates going up or down?
I'd just say here,
It's always
it'd be interesting to know about the answer to this question with respect to COVID-19. And really
I'm sort of going to go with the up.
I am too, just based on COVID and the proning that has to be done. Yeah.
All right, well, you all are correct. 68% said up, 32% said down. So now that we have the juices flowing a little bit, I'd like to formally introduce our key opinion leaders. First up, we have Kathleen Bullman, who is a clinical nurse specialist and consultant. Kathleen also co-authored the procedure for placing patients in the prone position for the AACN procedural manual. We also have Dr. Joyce Black joining us. Dr. Black is a professor for the College of Nursing at the University of Nebraska Medical Center. She's also a current board member and past president of the National Pressure Injury Advisory Panel. Last but not least, we have Dr. William Padula. Dr. Padula is an expert in health economics, a current treasurer, and the head of public policy for the National Pressure Injury Advisory Panel. So maybe Joyce, I'll hand it over to you to kick us off for today.
Yeah, thank you very much. What we're going to do with you today, we recognize the diversity in the backgrounds. And so we really didn't want to look at a single case of pressure injury because that really isn't going to meet everyone's needs. And what we wanted to do instead was look at a case that involved a hospital. All three of us work as consultants to hospitals, and we tend to get the same sets of questions. So we thought we'd blend our expertise together and look at this theoretical hospital. This hospital was made up. If it matches yours, I'd be very surprised. We just made this one up. So what we're going to look at are the processes of care. We're going to look at the risk assessments. We're going to discuss preventive care. And we're really going to do a deep dive into how patient movement can facilitate the reduction of hospital-acquired pressure injury. So our case is a 600-bed hospital trying to reduce its HAPI rates. That was one of the things that you all responded to, is that your HAPI rates are climbing. And what we want to do is, with Bill Padula's help, is really get a reality check on the cost of pressure injuries in the US. And, you know, even though Bill will present for you some of the national costs, he's going to break it down and actually look at what are you seeing at that individual hospital level, and how might you mobilize a team to help you at the bedside, which is more where Kathleen and I come in. You know, how do we actually get this work done at the bedside? So Kathleen and I are going to drill down into the processes of care, looking at risk assessment, skin care, mobility, and how we actually achieve a reduction in rate in any pressure injury in any hospital. And we're specifically going to look at ways that it is safe to mobilize patients, and at the same time, keep in mind, you know, our very tired workforce and the fact that we cannot afford to lose any more nurses due to injury at the time that many of our hospitals are in surge. So Kathleen, this is a magnet hospital going for its second attempt. It's a 600-bed hospital in a city of about 250,000 folks. It has both medical and surgical services. Their main financial gain is through their orthopedic cases and their open heart cases. Has a 12-bed ICU. You're very familiar with 12-bed ICUs, both medical and surgical patients. But what's happened And the reason the three of us got consulted is their rates in the ICU have jumped to 10%. So anything strike you about this facility that you just want to bring up for kind of our general thought?
Well, one of the things, whenever I see a jump like that, I try to look at, are there unit shocks or system shocks that have happened? Unit shocks being any leadership turnover, experienced nurse staff turnover, or a huge influx of brand new baby nurses. And I know some of the challenges with COVID, at least on the first surge, and it may be happening on the second surge, is you've got caregivers coming in that are assisting that may not be familiar with the routine practices within that particular ICU environment.
So we have had to, even here in Nebraska, we have had to hire a lot of travelers just to fill the gap.
Right.
With the huge number of inpatients we have in the ICU. So as you're saying, that contributes to what's going on because these folks are unfamiliar with all the practices of care that we would normally do. Bill, is this a hospital that's gonna see a change in revenue stream? What's gonna be the financial impact for them with this uptick in the pressure injury story?
Sure. Well, you know, if you want, Joyce, I could break it down kind of into what they really face here financially, because hospitals need to have good turnover in order to make money. You know, that's the key thing. And when a patient who ends up in the ICU develops a pressure injury, changes that rate of turnover. There's no longer a steady state of flow of revenue, and that's the real problem here. You know, a patient who develops a pressure injury, let's say within the first couple days, could be in the same bed for now another 2 to 4 weeks. And so by occupying that bed, they're no longer able to turn it over on that natural flow rate of 3 to 5 days. And each one of those patients bringing in, let's say, a DRG payment from Medicare that continues to cover that. So, you know, the real issue here is that patient with a pressure injury now, they're not reimbursable, especially if they're a Medicare or Medicaid patient. And in addition to that, they're continuing to cost money the longer that they spend there. So these are costs that certainly add up. And this is why prevention is so cost effective, or in fact, it's cost savings. You know, the upfront investment in the right amount of nursing time and the technologies that support the international guidelines for pressure injury for prevention are much less than, you know, continuing to occupy a bed for a non-reimbursable patient and the downstream cost consequences of managing those chronic wounds over a long period of time, and the malpractice costs that you might also have to face as a facility too. So astronomical, you know, Joyce, these are all numbers that I think a lot of people know, but we spend $26.8 billion a year in the United States just on hospital-acquired pressure injuries. It's a phenomenal number. And breaking it down at the hospital level, it's $150,000 per patient with a stage 3-4 unstageable pressure injury. And that doesn't include the cost of malpractice or the cost of not having the turnover or regular patient flow of new patients that you can bill for. So detrimental to hospitals as a whole.
$26.8 billion is an astronomical number. I can't get my hands around that number. That's some work that you did. Were you surprised to see that number that high? That was certainly not what was originally in some older numbers.
Right. You know, if you look back to the early 2000s, some of our colleagues in the NPIAP and elsewhere had come up with an estimate of $9 to $11 billion. So in the last decade and a half, we've more than doubled our costs on pressure injury care. And a lot of that has to do with the fact that the cost of care has increased at a natural rate. That's always going to happen. The cost of nursing time has gone up. And the cost of technology to handle wounds are more expensive. The good news is that these new technologies are also more efficacious. So they come with some bang for their buck, but ultimately we don't want to have to spend on things that we can avoid otherwise, and send patients home and give them a good quality of life and road to recovery. And this, obviously, this goes against all of that.
Yeah, it absolutely does. Well, I would think that the most logical place to start in any hospital system that's attempting to reduce its HAPI rate is to look at the processes of care. So Kathleen, let me turn to you with this. This hospital, we looked at their policies and procedures, and here's what we found. They want an admission assessment done within 24 hours of admission using two nurses, or sometimes people call those a 4 eyes assessment. And what they found in their review is that most of their HAPIs were greater than stage 2. In fact, they had a few that were first discovered as unstageable pressure injury on the heels. What's your sense of that policy? Are they where they should be at a national level?
Probably not. And one of the things that I would question is 4 eyes actually happening on that admission assessment? Are we missing present on admission wounds because they're finding them at such later stages? So that makes me think that it may happen. Also, if we're identifying risk well enough to put in preventative strategies from the get-go. And so those are the things that are sort of popping out at me right now. Just how much has some of these practices really become part of the fabric of the way the unit practices? Or is it just somebody going, I need a group of tasks done, so somebody wants me to do this, so therefore I'm doing it, versus truly understanding this is my way of preventing harm?
So one of the policies that we have commonly seen in acute care hospitals is that the regular staff registered nurse cannot stage the wound. The hospital wants this wound to be staged by a WOCN. They're in short supply. They're pretty thin. I know there's a number of WOCNs on the call this afternoon, and there's probably a handful of wounds you're going to have to stage when you get off this call. So when I look at that, I think, the American Nurses Association, as you well know, Kathleen, Bill, this is before your time. The American Nurses Association came out with a statement that said any nurse should be able to stage a pressure injury as long as they're given adequate education. And I wonder if this is a place where some of the technology within our EMR actually might be able to help them, because I agree with you that if this hospital is finding pressure injuries that are already open wounds rather than stage 1 and even unstageable, I agree with you. They've missed some of the opportunity to catch them early and keep them from deteriorating. You brought up, though, just an excellent point, and that is establishing risk. How do we know who's at risk when they come in? This is a hospital that uses the Braden score, and Barbara Braden lives here in Omaha with me, so I know she's appreciating the ongoing use of her scale. Bill, what's your sense of the utility, really, the functionality of the Braden in some of the hospitals that you've worked with?
Sure. Well, I think that the most important thing about the Braden scale is that it represents best practice. When you think back to a model for quality improvement that, in fact, the ANA and the ANCC use, especially with magnet designation, it's the Donabedian framework: structure, process, outcomes. And we can't achieve good quality improvement, best practices in nursing care, like for pressure injury prevention, without starting from a place of structure. That's what the Braden scale gives us. And that is what the NPIAP and the International Pressure Injury Prevention and Treatment Guidelines propose here, is that we need that structure, we need that checklist. And when it comes to risk assessment, the Braden scale is the best checklist that we currently have in order to look down at some major risk factors of patient risk for pressure injury, like mobility and sensory perception awareness and those things. That being said, with a lot of respect to the work that Braden and Bergstrom and others have done, it is becoming an outdated scale. It's over 30 years old, and it lacks some of the predictive features that we now know are incorporated into pressure injury risk. Simple things like age and skin tone, things that the Braden scale at the time didn't adjust for. So I think that the best way to move forward in the 2020s is to continue to use structure like the Braden scale or other scales that health systems use, and count on those to form best practices at the bedside, especially for an inexperienced nurse who might be on their first year on the job. Use that as a tool to guide the risk assessment process and add to that features of clinical judgment that make sense. So, where an individual is unique because of their skin tone or because of their age or other chronic conditions or drugs they're taking, bring in clinical experts, individuals like yourselves, to guide the less experienced nurse to fully risk assess the individual patient.
Well, and Bill, while one of the things I discovered, so the first time I did as a clinical nurse specialist, we had a pressure injury problem in our unit, and I did an initial evaluation, and what I found is 90% of my patients in the medical intensive care unit were under 12. And so it became more homogenized, not really directing the kind of interventional strategies. So a couple of things. One, in this particular, they do a fair amount of open heart surgery. And so one of the factors that's been added to the pediatric Braden Q that is not part of the adult is the perfusion issue.
Yeah.
And that's a big factor in the intensive care unit as a part of that.
Absolutely. I think that's a great example of how healthcare is evolving to update its instrumentation in order to be more considerate of the individual patient and not just treat all patients within a one-size-fits-all framework. But that's part of the process. Again, the Donabedian model, structure, process, outcomes. The structure is there. It's the Braden scale, right. The best practice guidelines for pressure injury prevention. But the process by which you implement a risk assessment tool can be using the Braden scale combined with clinical judgment or combined with other elements and features within the EHR that we simply know to be true as increasing the risk of pressure injury. Today, the big example is COVID-19, and knowing that these patients have acute respiratory distress syndrome, so they're not getting a lot of oxygen into their system, and they're bedridden in the prone position, so the tissue perfusion is concerning, especially in a few pressure points in the face down position. We know that these patients are high risk, and therefore whatever the Braden scale is, the score is, if it's 15, fine, but that score should be adjusted to reflect the acuity of the patient at that moment, or if they're taking a vasopressin or other things. Actually, this is new research, but for instance, colleagues and I just dug into an EHR, and we found that the vasopressin usage increases the odds ratio of pressure injury risk. So categorically moving from, let's say, a 15 on the Braden scale to a 10 by an odds ratio of 22.
Holy cow.
Well, and also Jill Cox did some work that showed the second vasopressor exponentially, as well as being on a vent for greater than 72 hours.
Yeah.
Was a 23 times higher risk.
Right. So those of you that don't work in critical care, just to kind of wrap you back into this discussion, we use a lot of vasopressor meds to improve blood pressure. The first line therapy, most of the time, Kathleen, I think I'm still seeing, is norepinephrine.
Yes.
But when the patient maxes out on norepinephrine, they go to vasopressin. So I think what Bill is adding to this discussion is the fact that when you keep compounding one vasopressor on top of the other, you know that this patient is extremely critically ill. And an odds ratio of 22 is astronomical. Yeah. But
Joyce, what I'd like to also say, Bill, when you talked about process, one of the process changes we may need to think about, there was a wonderful study done at the Mayo Clinic. It was published in 2012, where they looked at the correlation. They had 12,500 patients, retrospective analysis. They were already computerized. So they looked at any patient in the ICU and progressive care that developed a stage 2 to stage 4 pressure injury or unstageable. And then they went back and they looked at ICU demographics. They also examined the admission Braden. And they also looked at the Braden subscales. And so their overall rate was 3.3%, which was awesome in 2007. But it was interesting to note the Braden total score correlated at a 0.71. The subscales correlated at a 0.83. And what I found fascinating is there were two of the subscales. If you had a friction shear risk score of 1, you had 126 times the risk for the development of a pressure injury. And if you scored a 1 or 2 with moisture, it was about 50% of that. So my thought process is this concept of building a process where we're actually driving interventions off the individual subscales versus the more homogenized total number. There's something to think about.
So I think
study was
I think
really
it's actually been shown to be extremely helpful to look at where does the risk come from. To me, it's sort of like taking the temperature of a patient. They may have a fever, but you don't know where it's coming from. You have to do a little more investigation to figure out, you know, where the story started. Is it urinary? Is it pulmonary? And whatever. Bill, I realized I stepped over you. Let me give you a chance to come back in.
No, I think it's getting into some of the other work we've done, Joyce, and obviously we've thought about it for today's discussion. But the fact is that it's not the overall Braden score, but the individual risk factors, and really it still all comes down to factors like managing moisture and incontinence, managing nutrition, managing mobility. That's what prevents a pressure injury, not the Braden scale. The Braden scale is an alarm, and if the alarm goes off, you have, in my house, I got to run up and down the stairs and figure out where the fire actually is. So in this particular case, the Braden scale is the alarm going off, and then you got to figure out where the fire is in their chart.
That makes great sense.
You both have brought up the issue of immobility. And I think we all know and have known for a long time, right back to Hippocrates. They were called decubitus ulcers because people were immobile when they got them. So what we know about this hospital is that, you know, one of the ways we handle the immobile patient is we look at the beds. And if we can't control the duration of immobility, this is a patient that's critically ill and in the ICU on lots of vasopressors, can we control the magnitude of pressure against the skin and soft tissue? So this, Kathleen, I'm going to take your input on this. This hospital that we're consulting with has ICU beds that are somewhere between 10 and 12 years old. They're alternating pressure with continuous lateral rotation. And Bill, here's where you come in. This hospital says that they really haven't been able to get a capital improvement budget for the purchase of new beds in the last 5 years. So let me start with Kathleen. What's your sense of that old of a bed in a critical care unit, especially when we're seeing an elevation in pressure injury rates?
They're too old. The surface is not doing the job. And also now that we have guidelines from the National Pressure Injury Advisory Panel on what bed surfaces should be doing, it's imperative, the immersion, the envelopment, as well as the microclimate, that the bed surfaces that you have are up to that task, because you can do all the preventative strategies correctly, but if they're on a surface that is old and not doing the job, it sort of becomes a catch-22.
So, Bill, what do you think of the dilemma this facility's in? Is there a point of diminishing return on this bed, and what do they need to do to change this dynamic?
Sure. So first of all, I can point all the attendees. If you open up the chat box, I just put a link to a paper on PubMed that colleagues and I published a couple of years ago on the economics of support surfaces. And just to give you a little background, we did a cost effectiveness analysis of the investment in continuous lateral rotation therapy beds in the ICU. You know, those are expensive. Those are $50,000 beds for the ICU to help prevent pressure injuries and ventilator-acquired pneumonia. And obviously we found good results or we wouldn't have been reporting much, but these beds are cost effective, if not cost savings. So for the upfront investment of a $50,000 bed, which of course can be reused on many patients, they're high quality, durable beds, over the course of time, then as the rates of pressure injury and ventilator acquired pneumonia go down, these beds effectively pay for themselves. This was a risk that a chief nurse officer took. The chief nurse officer at this particular hospital, not the main Johns Hopkins hospital, but one of the other hospitals in the Johns Hopkins system, is on pathway to magnet. And she thought that this was an important investment to do research around and look at the clinical efficacy and economics in her health system. And we found great results on both sides of it, the economics and efficacy to report on. And this has become a valuable exemplar in our magnet portfolio. But to the greater point here is that there's lots of good quality technologies that are out there that support pressure injury prevention. And you have to come up with a whole bundle of technologies to support each of the elements of pressure injury prevention. It can't just be one thing at a time.
Yes.
You have to focus on pressure offloading and moisture and incontinence management, repositioning or positioning depending on the type of patient. All these things matter, and they all have to be done well at once. You can't just choose one thing, especially because we know that pressure injuries can come at you from mobility and from nutrition and from moisture and incontinence management issues. So you have to cover all three at once. Otherwise, it's like a Swiss cheese, slice of Swiss cheese, that something will get through one of the holes on there.
So Bill, this facility is interested in, obviously it's magnet status. And I know you're a commissioner with the magnet group.
I stepped off last year, but yes.
Oh, okay.
Well, dang it. Okay, but you still know something about magnet, I bet. How does magnet look at a problem like pressure injuries? I mean, do we have to be at zero before we can even try to apply?
Right. So, the key is, I think magnet, for those of you who are interested in magnet, but maybe not at a facility that's there yet, I think the key is to always start on the pathway, which is a program that ANCC offers for hospitals interested. And the answer is no, you don't have to be at zero pressure injuries, but you have to show that you're trying to improve. It goes back to the whole argument of, can we ever actually achieve zero pressure injuries in our society? The hope is yes. The practical reality is maybe not, but it doesn't mean that we can't keep trying and can't keep testing new models of teamwork, new models of leadership, and new models that integrate the right information and technology into our health system to support these teams of clinicians and leadership in order to address pressure injury prevention. So that is the key to magnet and moving on that path. And again, it's why when things don't work, it doesn't mean you drop something, but it means maybe you're missing an element that isn't capturing one of the major dynamics of pressure injury prevention. I'll keep repeating myself, but mobility, nutrition, friction and shear, moisture and incontinence management, that all these things add up. And so perhaps there's something missing from there in the whole process that you can continue to build on.
Bill, both you and Kathleen have sort of talked about some of the other hospital-acquired conditions, the moisture issue, so that brings up, the catheter-associated urinary tract infection. We sort of are trying to keep a lot of balls in the air here. And so the question I have to both of you is, typical, I've seen this in other hospitals, our own hospital, as a matter of fact, this hospital that we're consulting with just did this big project to reduce their CAUTI rates, and they got them down, and then their pressure injury rate came up. I want both of you to chime in. So Kathleen, I'll start with you. What's your approach to this? We've got one knocked down, but then we took our eye off the ball with the other hospital-acquired conditions.
And Joyce, in my consulting, I run into this all the time, and it's really about how the nurse views these care practices. It's really about this concept of do no harm, and this is my advocacy role. A lot of time, these care practices get viewed as somebody from a regulatory body is watching over me to do these tasks, and they're all in these separate buckets. So now the hospital's paying attention to CAUTI and CLABSI goes up, or pressure injuries go up. And as we've talked about, Joyce, it's the sort of whack-a-mole. And so really looking at how we can address this comprehensively, instead of having champions for each of these, put them in collective buckets. And I think Bill's going to talk about this. For me, I look at two buckets: an infection prevention champion and a mobility champion. The infection prevention champion manages the bathing, the oral hygiene, the C. diff, the hand hygiene, the CAUTI and the CLABSI. The mobility person is looking at pressure injury prevention. They're looking at falls. They're looking at safe handling. And so that's their buckets, so that we look at this and also present it as this is our job as professional registered nurses in preventing harm. So Bill, do you want to?
Yeah, is there a chance, Joyce or Jenna, could we pull up that slide with the Venn diagram again? Because I think it's a great visual for what we're talking about here.
You got it.
Thanks.
You got it.
I'll wait for it to pop up just to guide our discussion. There we go. You know, I believe that this is exactly what Kathleen just said, you know, or at least referring to the mobility and the infection control. You could see infection really truly overlapping with two of these bubbles, with the moisture and nutritional issues. But that, you know, whether it's oral hygiene or you know, keeping surfaces clean, obviously that those are issues that add up. The bottom line here is, from a magnet model in nursing care, pressure injury prevention and the whole whack-a-mole concept of where do we focus, whether it's on pressure injury versus some of these other issues, comes from leadership. Leadership need to be there to dictate how do they structure these teams to support these individual efforts. And it's true, if all you do is focus on CAUTI or focus on DVT, then these other things will come back up. Give it enough time if you think you've solved it. But instead, if you take a top-down approach and think that these are the overlapping issues: nutrition, mobility, moisture, or I love how Kathleen put it, where it's mobility and infection issues. Either way, that if you structure teams around addressing those needs with every single patient, then you have 3 teams working together on a common needs assessment of the individual patient, and it doesn't become so complicated. It's more, sorry, I've got my fire alarm actually sounds like it's going off in the back.
But especially when you use the fire alarm example earlier. That's good. testing me out. Life doing these panels at home, I guess, right, in the times of COVID. But you know, it's much more economical to have 3 change teams focused on these overlying issues, rather than have 15 change teams to address the needs of how are we going to prevent pressure injury or CAUTI or SSI or sepsis. Like, that's so much more complex. It costs more money because you need more teams. And each team is going to be asking for individual budgets that overlap so much in terms of the material and time-dependent needs to address these issues. So it seems practical that health systems move towards this type of a top-down approach and address everything at once. It no longer becomes a game of whack-a-mole, but a strategic effort to drive everything down based on the common issues.
So while we were making rounds in the hospital, this issue of mobility, which we have talked about several ways already this afternoon, came up. And what we noticed was that when we were making rounds in the critical care unit, everyone, and I mean everyone, was positioned semi-Fowlers with head of bed at 30 degrees. And we were told that a fair number of nurses were injured on the job trying to move these people. The hospital has not been able to afford an over-the-bed lift system. And I'm wondering what my panelists think of this. Bill, if the hospital looked at a lift system or something even temporizing, lifting help Is there a good return on investment on that?
There's got to be, because when you look at as it relates to this diagram in front of us, it really is a focus on managing mobility. And what's great about lift systems is it doesn't just help the patient, but it helps the clinician too. Hospitals spend a lot of money on workplace injury, and obviously that isn't just the cost of doing business, but these are not individuals that are inexpensive to replace, when it's human capital. And certainly the primary point is you don't want them to get injured to begin with. It's just not a good reputation to have as a work environment. And again, that's another thing that Magnet looks at, is nursing satisfaction. If a hospital starts getting a reputation for a place where back injuries come into play as a result of repositioning for pressure injury, that's not good for nursing satisfaction or for outcomes. So, as a whole, the costs are additive beyond just how are we doing with pressure injury rates, and it brings in a whole nother dimension of issues that we don't want to have in the first place.
And the way, so Bill, I see it very similar, but I also see it from a practical application. I live in a perfect world, and I work to get everybody else to live in my perfect world. And my perfect world does include ceiling lifts, but it also includes in-bed mobility strategies for shear and friction, for simple positioning. And then in my perfect world, I have the lift system that circles around the bed so I can ambulate a patient around the bed, one nurse with a system. I've got a track going to the toilet. I got a track going out into the hallway and a track running in the hallway to maximize support, so that even if I have turn teams or structures like that within my system, I have all the right tools for either the frontline staff nurse or a turn team to be able to do it safely, to protect shear and friction for the patient, to support the correct positioning, and also to foster early mobility for the patient without having them fall. So I sort of look at it in that comprehensive kind of bubble as well.
So Kathleen, we certainly have seen the benefit of proning, something that you've been writing about doing and teaching for a number of years. Mechanically, what do we need to get that done? I mean, the overhead lift system isn't going to help us here. So what's your view on that?
Yeah, I found some challenges. Unless the complete culture has changed, the likelihood that a nurse is going to either get a portable lift or use the lift to move somebody 2 inches in bed, to move them up in bed, or even to do the turning. So looking at systems, systems that are breathable, that are shear and friction resistant, and also incorporate wedges versus pillows, because pillows don't create offload for those patients at high risk, to reduce the risk to the staff and to make it happen for the patient. And then also there are, similar, like the mobility coaches or mobility techs, or turn teams. Some systems have turn teams, things like that to help. Because I got to tell you, what I've discovered is the likelihood that a patient, especially on the critical care side, is going to get up and walk without even being turned in bed goes down exponentially. So it really starts with that in-bed mobility component, then moving and progressing to the out of bed.
Yeah, I think progressive mobility has really become a key to recovery with lots and lots of patients, and finding a safe way to do it is really instrumental in, giving them a better life and giving nurses that can work uninjured. We're going to wrap this up with just a couple of comments before we open it up to the Q&A portion. Bill, the current NPIAP guidelines have 2 items that are listed at an A level of evidence and a A level of development. That means they really don't have any reason not to do them. One is to develop a quality improvement program to reduce the incidence of pressure injury. And the other is to provide education on pressure injury prevention and treatment. How would you recommend the hospital structure itself to get those two done? I don't think they can simply ignore them.
Sure. Yeah. So given I've done a lot of this research myself on the fact that quality improvement practices work for pressure injury prevention as a major hurdle to overcome, and nursing education, continually educating nurses as these new guidelines on prevention come out every several years. And the NPIAP schedule, it's every 5 years. Since the one just came out in 2019, the next one will be in 2024. But putting together a plan to educate nurses on that cycle about updates and best practices for pressure injury prevention does work. It's statistically significantly and clinically meaningfully has been correlated with a reduction in pressure injury risk. So that being said, it always starts with structure. Again, structure, process, outcomes. I can't emphasize it enough. And in this particular case, the structure on the macro level of doing quality improvement, what colleagues and I found is you have to have a team that is focused on pressure injury prevention. You have to have a champion and leadership who's prepared to support you. So if that's a chief nursing officer or your division director of nursing education, nursing quality and safety, that's who you need to have your back in order to get the finances and to bring people's time into play to form the team to address the needs of patients with pressure injuries across a facility. Without that, it's hard to get all else going. Once you have the leadership and the team in play, everything becomes straightforward. That there are the key elements of a good pressure injury prevention protocol, the risk assessment upon admission and skin checks and repositioning and managing moisture and incontinence and good nutritional practices and good bed surfaces and pressure offloading. It all adds up. And the technologies are constantly advancing now. I think that's a really interesting part of the field. So you need to form that team and do an assessment of what are the resources that you don't have that you do need to facilitate improving pressure injury prevention. And the challenge is today that those are investments. They cost money, but they're not a loss. The reason why it's an investment is that over time, you should be able to get your money back. So if your pressure injury rates are high today and you're spending millions of dollars on pressure injuries, from an economic standpoint, it should only cost you several $100,000 by comparison to invest in the right technologies that eliminate pressure injuries. And then with that return on investment, the justification to the C-suite, to your chief nurse officer, chief medical officer, is the fact that over time, with the elimination of pressure injuries, there will be money that opens up that you can allocate to other causes within the hospital as well. So quality improvement is contagious. And by starting with pressure injury, you're definitely creating greater financial bandwidth.
So Bill, what I'm hearing you say is starting with a gap analysis to see where your organization is at with regards to their pressure injury prevention status.
Yeah, like the old thing, look in the supply closet and see what's missing.
That's one of my favorite places to hang out.
Oh yeah, I love this story. I'm sure many of you heard of Peter Pronovost, who is someone who's done a lot of work on checklists and quality improvement. And he used to talk about how at Johns Hopkins Hospital, all the supply closets were a mess. And his first quality improvement project before he started doing the checklist for CLABSI central line insertion was to just get closets organized around the hospital. And when he did that, outcomes started to improve, realizing where things were, that there were resources available to fix some of the problems that were already there. And also realized became a gap analysis of noticing what was missing in the closet that they did need. They were able to update everything and keep moving along.
Well, let me tell you what the team decided to recommend for this hospital. We recommended that they educate their nurses to do an accurate admission skin assessment and really get a handle on the pressure injuries. We recommended that they use the Braden scale, looking at its subscales, and that they implement specific interventions for those patients on vasopressors that are in the ICU. We did see a lot of difficulty in turning people in the ICU. So we recommended that they implement a turning team and they get some help turning the patients because the overhead lifts were beyond their scope at this point. We did strongly recommend that they upscale their beds. But with that effort, we thought we tackled it from the angles that we felt we'd give them the biggest bang for the buck. And so we worked on improving the structure of how care was organized, delivered, and the education was done. And that now it will be their job to implement a process that works, and hopefully they'll see improved outcomes. It's usually what we hear from these consultations. Let me stop and absolutely thank my panelists today, Kathleen Volman from Michigan. Nice to have you on, Kathleen, as always.
Thank you, Joyce.
And Bill Padula from sunny California. It's hard to see the sunshine with that background, but we understand it's sunny out there. Thank you, Bill, for joining us. The economist view is always fascinating to me, and Kathleen, of course, brings a wealth of critical care background. So let me turn it back to you, Jenna, and see if you have questions you want us to address.
Yeah, we sure do. We have quite a few, and we probably don't have time to get to all of them, but rest assured, we will send out the answers to all questions post-webinar. So let's start with, we have the first anonymous question was, what 2 or 3 tools would you use when approaching the C-suite for resources to address HAPI risk in the ICU?
You know, I'll quote a famous biostatistician who worked in healthcare, Deming, who said, "In God we trust, all others bring data." You know, if you can show your problem using real numbers, then you've got a real problem, because you only have about 30 seconds to grab a chief nurse officer's attention before they realize whether or not you're blowing smoke in their face. And the data tell the true story. So I think it's a combination of epidemiological or case numbers combined with information about the financial impact that this could potentially be happening. I say potential because you don't have to do the exact calculation or hire a CPA in order to do the numbers for you, but give a ballpark estimate of how this is hurting their hospital. If the C-suite doesn't already know their numbers, which I'm sure with a lot of good hospitals, they do know that pressure injury is costing them. So, you know, in terms of the epidemiologic data, I'll post another link to a paper that we published that goes through this, but telling at a hospital level what the number of pressure injury is important. But again, like, where's the fire alarm going off in the hospital? Being able to tell them which units are really problematic and what types of patients or what locations on the body that pressure injuries are occurring are probably the most important things, because then you can pinpoint and say, we don't need resources for 500 beds to prevent pressure injuries. We have this 8-patient unit, you know, cardiology ICU, and we need to focus on helping those patients get better. And if we do, we only need a team that's focused in that little area, and it'll cost us a small amount as opposed to a bigger hospital-wide amount. So, you know, those are the key data points, I think, from that standpoint. You know, we also have the economic information at our fingertips, like the fact that a stage 3-4 unstageable pressure injury costs somewhere between $75,000 and $150,000. That's at baseline, and that's not including the malpractice and all and the turnover or loss of other billable patients, the opportunity costs, as we would put it. So at least starting from that standpoint of, if you've got 10 cases per year, you're essentially spending $1 million on pressure injuries. And if you could reduce that by 50% and make that a quality improvement goal, saving $500,000 is a market improvement. And perhaps the ask becomes, hey, if we could have $100,000 to invest in recruiting a better team and getting new materials and resources, then that $100,000 could lead to a 400% return on investment by getting back $400,000 in savings on pressure injury expenditures.
So Jenna, can we tell the audience that the links that Dr. Padula is talking about will be emailed to them?
You got it. They absolutely will.
Great.
Yeah. So I think we have time for maybe one more question. Has anyone seen a dedicated turn team or a wound care resource person positively impact HAPI numbers?
Yeah, I have. I consulted with a hospital in California about 18 months ago, and they had tried to figure out how to reduce their ICU rates. And so what they did is use their techs that were on site, and they knew the patients. And so they were able to just assign 2 techs every 2 hours to go and move all the patients. I know that the Mobility is Medicine group through Atlas Lift Tech has multiple examples of using a dedicated set of people who know how to turn patients. And where we've really seen it play out is in the COVID story, because of all the need to prone people and a very unique skill set to make that happen. It has to be done safely for the patient. It has to be done safely for the staff. So yes, on both counts, general turning of critically ill patients, and then specifically turning the COVID patients into a prone position. Seen it both, and reduced pressure injuries in both.
Thank you, Joyce. Well, we don't want to monopolize anyone's time. We're coming up on the top of the hour. I want to thank our 3 key opinion leaders for taking their time to provide this education. It was wonderful. And we hope that you all will join us for the next series. TBD, but you will be sure and be updated via email, via Facebook, LinkedIn, or on mobilityofmedicine.org. So thank you all for joining, and we'll see you next time.
And we'll send out answers to your questions.
Yes, we will. Thanks, everyone.